Welcome to this special episode. I'm your host, Dr. Nadine Ferris France, Executive Director of the Irish Global Health Network, and it's great that you can join us. We last spoke to Dr. Mike Ryan about a year and a half ago in a conversation that really has stayed with a lot of us. And since then, so much has actually changed across the global health landscape and across the world. So today feels like the right moment for us to come back together, to reflect on what's shifted, to really look at what's happening right now, and in particular to look at where are we going if in fact we know. I'm really pleased to welcome Mike back. Mike, thank you so much for making the time to be here. As most people will know, Mike was the former Executive Director for the World Health Organization, and before that, the World Health Organization Humanitarian Emergencies Programme, and before that has a very long history of working as a clinician and an epidemiologist in humanitarian and emergency settings all over the world. So welcome, Mike, and thanks for joining us.
It's great to be here. I can't believe it's a year and a half.
I know.
Wow.
I know.
Oh.
And speaking of things changing, it's been about 5 months since you left your position in WHO. So first of all, we're delighted that you're back. So welcome home. And what's the transition been like for you so far?
It's been great. First of all, it's great to be home. It's great to be walking around the streets of Dublin today and knowing I was actually going west, not to the airport. So it's those feelings of knowing you're home, spending time with my kids. Son has moved in with me. He's in college, but he's a guitarist in a band. So my house has become a band venue and a student house at this stage. So it's just nice to be home and live in that. And with my mum and my elderly relatives, it's just nice to be around, you know. Yeah. So I haven't regretted it yet.
Great.
I haven't. Some morning I'll probably wake up and think, what have I done? But so far it's been great.
Maybe not. Maybe not. Yeah. Well, welcome home. And if it's okay just to kind of take you back, we're very interested in just your perspective on what's happening in the world. I mean, last time we spoke, it was the end of 2024. COVID still felt like the most defining global health crisis of our time. Since then, we've had more conflicts, we've had funding cuts, geopolitical shifts, services disrupted in many countries, treatment for diseases like HIV and TB disrupted, health workers have been made redundant. Just from your perspective, how do you see the state of global health right now? And, you know, looking back over the past 12 months, what would you say are the defining health issues of our time? What changes are you seeing?
Two big questions there. I'm an optimist by nature, and there has been a lot of change, and a lot of change for the negative. But let me first maybe start with some of the positives. Over the last number of years, we've really seen a massive growth in capability around the world in the health systems in terms of the human resource, health workers, science has improved. I think we were in a moment of great hope over the last few years, that things were shifting to local capacity, that we were shifting to a fairer, more equitable world, that the idea of multi-sectoral response to health, and that health being a pan-societal issue, mental health was getting on the agenda. So you look at that and think there was great momentum in a way to transition to a different, more sophisticated way of looking at health within the ecosystem of society, looking at dignity, looking at inclusion as big issues, not just at outcomes like mortality or disability. And so all of that was happening in a sort of a positive way, despite the constraints that we always have in the public sector. But we've seen, this sort of the legs have been chopped out from under the global system in many ways, and in some ways that's, I suppose, inevitable, in that systems have to change. And if the system was going to evolve into something for the 21st century, it was going to have to change. But the kind of changes that have come have been unwanted, too fast, too brutal, and not necessarily aimed at improving the system. Some of the change has been aimed at actually destroying the system. So we're all of us working through all of that shock, and that sort of, in some senses, the paralysis that sometimes comes from that shock. And then picking up the pieces, it feels like, it's after an incident like a bombing, and everyone's just a little completely out of it and just trying to find what's still here, what's damaged, what's not, trying to pull things back together, pull each other back together, and get on with it. And that certainly happened. And, you know, we're seeing that collapse in funding, that shift. Now everyone says, well, now we don't have any money, so it's time for you developing countries to be resilient. So we've come up with new ideas around, well, we can replace that with resilience. That's fine, but that doesn't just happen like that. The climate issue is now really starting to drive poor health outcomes. That's becoming more and more intense. Mental health crisis becoming more and more intense. And the issue of conflict around the world is destabilizing global economies, which will ultimately affect health systems everywhere. But specifically in fragile countries, we're moving from an emergency response mode where you have, you know, somewhat stable situation with intercurrent or occasional conflict that has to be dealt with through humanitarian intervention, to permanent conflict. And that conflict shifting within countries and between countries, both in terms of the timing, the geography, even the type of conflict that goes on in a country. So it's got very complex. And that's the thing I'm most worried about, is that there are 30 or 40 countries in the world that are just drifting away from the rest. And they're entering a zone of permanent fragility in terms of climate, permanent fragility in terms of conflict, permanent fragility in terms of governance. And it's in those countries, I think, we need to start thinking about development and humanitarianism together. These countries can't have separate ideas for what's happening, because that's where the women and children are dying. That's where the health services are not existent. And that's where we're going to lose most human beings over the next 20 years. It's going to be in that very concentrated area. But it's very hard to operate in politically, very hard to operate in from a security perspective. Very easy to get manipulated in the aid and development cycle. So, yeah, there's a lot to do, but you know, there's a lot of hope too. I mean, artificial intelligence is bringing new hope, new vaccine and therapeutic technologies. You know, we're getting better and better and better at the science. The problem is that that's been distributed unequally again. I was looking at a stat the other day, just a simple stat, that the people working in artificial intelligence are about 85% male. So if you just look at the issue of gender equity, we already are introducing inequity into the delivery of one of the greatest inventions in health for the last century. It's English-based, male-based, northern-based. Right. All the things we've tried to deal with as a society globally are being potentially reinforced by this wonderful technology. So, you know, they're the things we really have to address.
That is just so, there's so much in that. And, you know, I love that you focus on the hope. At the same time, you bring us to such, such awareness of the realities. I guess maybe to dig a little bit further, you know, we talked about the funding cuts, and we know, I mean, all of us are, you know, have been significantly impacted, particularly our colleagues and friends in the Global South. And it's been like, you know, certainly from where I'm sitting, like a big game of Jenga. And whether I don't think it was a good game in the first place, but the blocks were filled in by countries and by different various donors. And when the Trump administration pulled the blocks, it was like the whole tower started to crumble. And then, of course, we end up with the system under real strain. You talked a little bit about the long-term consequences of those funding gaps in what you just said there. What about this whole area of what we're now calling self-reliance, integration? We're looking at countries like Namibia and Uganda as they move towards greater self-reliance. Like, what's your perspective on that?
And it's a great thing. It's something I've worked on my whole career, moving away from vertical systems, reliant on aid, reliant on philanthropy, to more inherent capability within countries where countries themselves direct what they need for their citizens, and citizens have the right to define the healthcare they want. So that's what we all want. It's in some ways we have that view in Ireland, that's what we want in healthcare in Ireland. But
Yeah.
but for people abroad, it's a different kind of more paternalistic,
Interesting, isn't
more neo-colonial view of you'll take what you get, because it's a do-gooder syndrome.
Right.
So we have to avoid that. So maybe this is a time to move on. You said there about the Trump administration cuts. They were very severe and swingy, but it's not just
Right.
the US administration.
Right.
Everyone is hiding behind that flag, and they're reducing their ODA. So Ireland is a singular exception at the moment.
That's right. Yeah.
Increasing its ODA. But the reality is many countries are moving away from development assistance, even from humanitarian assistance in general. And it's forcing countries into that concept of self-reliance and I was in Uganda actually the day some of the big cuts were announced during the hemorrhagic fever outbreak there, and it was interesting I was with the minister actually in the bush when this whole thing came to light, and she made an off-the-cuff speech and spoke about we need to be more resilient, we need to be more self-reliant, we need to now take this. Now, clearly at that time she was probably thinking, oh my God, I need to do something here to give people hope that the whole system is not going to collapse, and they've done a very good job. But Uganda's a complex place.
Yes.
Very complex in terms of disease, complex in terms of the system, the ethnic divides, everything else, where it is on the development cycle. Namibia is a bit more easier, smaller population. So they're two very different case studies, I would say. For resilience or for self-reliance. But it's interesting, there's one thing is what you do to create self-reliance, the other thing is what you actually stop doing to create reliance. I remember I think it was in Nigeria a number of years ago, talking to the Minister of Health, and he said to me, Mike, I have over 80 different organisations in Abuja here with health representation. And he said, and they all have a plan for me. He said, the only plan they have not read is my plan. So that existed years and years and years ago. This external setting of priorities.
Right.
So it's not about self-reliance, or you need to be now self-reliant. It's about self-determination. Yeah. And if you give people self-determination, no more than ourselves in Ireland, people will absorb that, will take that on, and will find a way. But if you say to people, well, we're not going to give you true self-determination, we're going to make you economically dependent on us for the rest of existence, and by the way, here's a few dollars to support your vaccination programs, people take the money, they chase the money, and they're conditioned into chasing aid. Chasing aid, find the money, and we do it ourselves in the NGO and the UN community. So it's I do think transition is possible, but and yes, I mean, I've been very blunt about it. For many, many years, there was a lot of money that's been pumped in by ODA and by Philanthropy and others, and there's a tremendous amount of corruption that's been generated from that. And let's be very honest in that, right? I've worked at the coalface for 30 years, right? And the things I've seen happen with funds, and it's scandalous. NGOs or philanthropies given to organisations who then give to NGOs who give subcontracting down through the system, and each one charging 20% overhead. By the time the money gets to the field, there's nothing left. Yeah. So sometimes maybe just taking out all those middle organisations and trying to deliver the money more directly to community level is probably a smarter way to go. But to do that, you have to build in community accountability, individual accountability. You've got to develop systems where someone has to be accountable, be it domestic funding or international funding. I think somewhere like Namibia could probably move to a more domestic funding architecture fairly quickly with some assistance from aid. But I think Uganda is probably going to be very much needing external help with its systems, because it's that complicated. But it is possible. But every country in Africa is very different. I don't know why you give the two examples, but they're two very different examples. But at least they're relatively stable countries. If you go to Congo, or go, my God, or DR Congo, it's a very different thing.
Yeah, I mean, you're talking about organisations, and in a way that kind of brings me on to reform and UN reform. I mean, we're in the middle of a massive UN reform agenda as such. And we were speaking just before, and we talked about, that global aid architecture was set up over 70 years ago when the UN was created and all the various agencies. Can the UN system adapt? Should it adapt? Or are we moving towards something fundamentally different?
Yeah, it depends which UN you speak about, the political UN or the humanitarian UN, or what, they're very different animals in that stable. There's been a huge proliferation of UN entities, UN agencies, UN this, UN that, UN the other. People are confused.
True.
There's a lot of duplication in the system, and certainly it could do with being streamlined and being reformed. The problem with the word reform is very pejorative. It's interesting how philanthropies use the word like the UN needs to be reformed. I wish the philanthropies would do a little bit of reform, to reform. To reform means it was malformed. It wasn't formed correctly. So there was an inherent criticism in this. For me, you need to evolve for the circumstances that you face. You need to work with the system you have, not the system you'd like to have. You have to work with the realities that you face, not what you think would be nice to have. Right. So in that sense, to evolve the system to be more responsive to a new way of doing business, localized, community-led, with much more reliance on national systems, that means relying on national governments. And many UN and philanthropy and others, ODA, have undermined national governments on the basis that they're corrupt, they don't get the work done. Now we're all talking about national sovereignty and self-determination. It's great, we're all on the bandwagon. Right. I've worked for 30 years building national systems. And I'll tell you, I didn't get much money. We didn't get much money when we went in with proposals to build national surveillance systems or national response systems or national health systems. You want to talk about systems, everyone they start yawning. Oh my God, he's talking about systems again, Now it's the new sexy word, right? So that idea that the UN is the fault that needs to be reformed, right?
Yeah, I love that.
At least the UN, say WHO that I work with, has 194 member states, and the ministers of health of every single one of those states comes to Geneva once a year, and in 6 regional committees, they at least have the democracy of having a vote to say what happens. Yes. No such votes happen in the Global Fund or in Gavi or in any of the other big philanthropies or the big institutions. They have boards that are supposed to be representative. So the UN actually is fundamentally a very good example of a democratic process, but deeply flawed in its implementation. Now, what do? Do you throw it out? Or do you try and say, we have something here. Look what's happening now in the world, the lack of a rules-based order. Where the hell are we? So that's on the more political and security side. So, I do think it is possible that the UN can evolve. It needs to be less complex, clear priorities, clear responsibilities for the different agencies. But actually, it's not a bad idea.
Yeah, amazing. 70 years 70 years and still not a bad idea. And speaking of ideas, this whole, thinking about global health and this whole idea of, rethinking global health, that's what we're talking about a lot in the sector at the moment, including us here in Ireland with the Restore Humanity campaign. We know it's not business as usual, but what should it look like? I think it's fine to say, we need to rethink global health. It sounds exciting. I want to get behind that. But what could it look like? And I think I'm particularly interested to know from your perspective, if you were redesigning global health, what would that look like?
We spent a huge amount of time working on building the capabilities of national public health agencies. Not specific institutions, there could be networks of agencies, there could be a building, but the idea that every government needed to have its Ministry of Health. But what was missing very often at government level was a semi-independent body that could do science, do policy, wasn't completely turned over every time there was a political change or a coup d'etat or whatever it was, that there was some stable entity that would continue through with public health at its core. Now, we've got to a point, I think 10 years ago, we only had 15 or 20% of countries had a national public health agency. Now 85% of countries have a national public health agency. Mozambique is one of the finest national public health agencies in the world. It's got a fabulous director. It's a brilliant base to move from. So I think that idea of Yes, returning to self-determination, but then creating the platforms at national or regional level that allow that self-determination to become a reality and to be driven by excellence. Not self-determination as second best,
Right.
but self-determination and self-reliance as the best solution. And to do that, you have to really put the platforms for excellence as close as possible to where the problem is. Not a UN office in the country, like a WHO country representative driving around in his Mercedes-Benz and the flag on the roof, right?
Yep.
But actually, or another UN or some philanthropic institute with its director, and they're all driving around in their desert-adapted Land Cruisers, and they meet at the Melia Hotel, the Monster Hotel at the weekend, and they go to the British Club and do whatever they do, right? That's not,
That's not it.
No, that's not it. I'm talking about investing in the national architecture.
Right.
And then accepting that that national architecture won't set the priorities you want it to set.
Right.
It'll set the priorities that it sets with its population. Some of the time you'll be very happy with those priorities, and some of the time you won't, just like in Ireland when it comes to the health system.
Right.
So getting comfortable with the idea that aid doesn't direct investment.
Right.
National authorities direct investment, and then the investors from outside are then investing in that. I mean, someone buys shares in a company, they don't go to every meeting and every board meeting and tell the company what to do. They're showing confidence in the company's approach by investing and buying their shares or whatever it is. But then the company get on and do business. If the company does well, it does well. If it doesn't do well, it folds or whatever. So I do think there's a way where I've seen a huge, for example, we take Africa and you use the example of Uganda. The amount of talented professionals that have emerged in Africa over the last 20 years is astonishing.
Yeah.
It's astonishing. And they're out there. And they need to be able to, like me, go home and serve their own countries. A lot of them are out there in a massive diaspora of science and public health and clinical medicine. We need to incentivize those excellent individuals to be at home and contribute to their own system. And until there's good governance in the country, until there's good oversight, until there's a reduction in corruption, until there's a fair system of transparent system of promotion and appointment, they're the things that are going to attract someone back. I mean, it was the same in Ireland many, many years ago when Bob Geldof called us a banana republic, right?
That's right.
Where no
Not
one
so
could be
many
sure,
years
especially
ago.
as a female, you could not be sure to get, even until a very few years ago on the academic side of things. It was almost impossible for a woman to be appointed in a professorial role or a head of an agency role. It was a huge uphill, and it's the same way. We have to create the conditions in which those individuals can return home. And I just see great hope in the people. The system matters or doesn't matter. But if we invest in those individuals, no more than our own country has dragged itself out of poverty and conservatism by the power of its own people, I think the same is true in many developing countries. And they're different. Africa has different challenges to Asia or to South America or to North America. Like the inequity in North America, or particularly in the United States, not in Canada per se, but the inequity within the country, and it's emerging in Ireland too. I tell you, we're heading very fast towards an inequitable health system within our country, while we fight for equity globally. Which is a bit of it's a little bit of hypocritical at times. But it's. If you look at Asia, Asia's made huge progress in terms of basic parameters like immunization, mother and child health in general. I mean, there are exceptions like Afghanistan, but if you go to Southeast Asia and the Western Pacific, they've, Indonesia, they're the most amazing health system, and their ministry people and their institution, they're running like emergency medical team training center for the whole of Asia. So the old idea that all developing countries are sort of the same, Asia has moved on. And it still has issues with internal equity and fairness and whatever else, but it's on a trajectory that it's moving forward. You mightn't like the regimes, you mightn't like the politics, but they're moving. Same in South America. Within reason, systems are improving. There are exceptions in every region, but in the Middle East and in Africa, we've got to back to that idea of there's 20, 30, 40 countries, depending on how you define it, who are literally, there's like a tectonic plate has opened up between the world and them, and they're going backwards.
Right.
And they're going backwards really fast. And all of those gains in malaria and TB, in maternal mortality and under 5 mortality are just crumbling. And that's where I think that's the biggest issue for me.
Yeah. Well, you're very passionate about that. You're all, you no matter what platform you're speaking on, you're always talking about the countries in conflict. I think it was only in December last year I heard you speak like 120 armed clashes in over the past 3 years. I mean, I think that's incredible. But what do we do about that? How can the world respond?
Well, if Ireland or we as a nation are values-based, right?
Yeah.
Let's say we have a values-based approach to things, and that's great, it's fantastic, but values need to be followed by actions. Values don't feed the poor, values don't stop attacks on healthcare. But at the same time, you can be a huge member of the Something Must Be Done club, and, tut at all this violence and everything else. Or you can, in your area of expertise or knowledge or your area of power, you do something. So yes, there are huge solutions that are needed to stabilize the world, stabilize these countries in permanent conflict, and that'll have to come. That'll come not from me and not from you.
No.
So those of us who work in development and humanitarian response have to say, what can we actually do in those settings? And it's very important that governments like the Irish government don't disengage and give basket case status to some of these places and say, we're better off doing nice work in nice stable places where we can see the results and we can get the photographs taken and make the posters and do whatever. It's nasty business in some of these countries now. There is no thanks for it.
No.
There is no positive flag waving for it. You're essentially saving lives at a destructive coalface, and most of that work is never seen because what you build gets destroyed the next day by a bomb. It's building that core resilience at deep community level for which no one will ever cut a yellow ribbon. That's the hard part. And it's really important as Ireland maintains its aid that it refocuses a little bit on those really difficult situations, because Irish aid's money can go an awful lot longer way in those settings, than just purely being project-based development stuff,
Speaking of conflicts, last time we were together, Gaza was, we were talking about Gaza a lot, and you were right in the thick of WHO's response and support. What happens when that kind of the rules-based approach isn't translating into protection on the ground? Like, what options are actually left, and what kind of actions should Ireland be thinking about?
Yeah, it's very hard. I mean, before I left WHO, one of the, I lost it at a press conference one day, just completely. I just, like that, I was like at the end of my tether, just completely, beside myself. And I'm as many other people were, because it's really hard question, because you say to yourself, why do I keep knocking? Why is we have to knock our heads against this wall? But we just have to keep going.
Right.
And bearing witness becomes something in itself. Because eventually, down the line, the investigations will come. Hopefully. You have to believe that at some point there will be justice for this kind of thing happening. And it doesn't matter where in the world that's happening. The idea of bearing witness, the idea of sticking with communities, the idea of staying out of the politics if you can, very hard at times. But, as I say, if you believe in the values, then you're able to have the action that goes with those values. But then the likes of those who can do other things, like the Irish government, need to be consistent too. If you have those values at a political level, then you've got to take political actions. Right. And some of those actions aren't always that comfortable. I think Ireland has done a good job overall. But a lot of other countries, I'll say, have just been utterly spineless when it comes to breaches of human rights and fundamental breaches of international humanitarian law and the law of war. Just incredible. And that's happening in multiple zones. It's not just in Gaza. It's happening in multiple situations. And it's very hard. But the problem is that paralysis comes when you say there's nothing we can do. Yes, there is.
Yeah. And fear.
Fear, but political fear of making a mistake and then suffering a consequence for us. Same for us in humanitarian or development world. You put people in the field all the time. Right. You lose people, and you've signed their orders to go. That risk is there all the time. Mm-hmm. And there's always a chance that you make a mistake or that you get punished for your views or your approach. But I think you have to not separate, but you have to do what you can on the humanitarian and the development aid side and helping save lives. Right. But you can't keep just saving lives. Someone's got to turn off that tap. And the only way that can be turned off is conflict resolution and the political side. Mm-hmm. And for me, I'm just in abject horror at the way the Security Council has just become, it's worse than a talking shop. It's just beggars belief to think that is the best we can do in terms of global governance. It's ridiculous,
Yeah. Yeah, I mean, you're talking about, and it's good that we're talking a little bit about the Irish government and what it can do. And you mentioned it just a little bit earlier, that Ireland is among one of the few countries that's increasing its ODA compared to most of the other countries that are actually investing ODA money in defence budgets. Mm-hmm. In terms of Ireland, we're not such a big country, relatively speaking. Resources are finite. Mm. So what should Ireland protect in terms of its direction and those resources? What should it not do, and what should it do? You've mentioned it a little bit, but specifically, resources are finite.
I think hard and all as it is to say that the government should be trying to move away from project-based funding. Yeah. Into funding human resources, funding workforce, fund systems like those national public health agencies or national surveillance systems or national nursing training programs. You won't get as many yellow ribbons and not as many headlines, but you will build resilient infrastructure. Supply chains. Yeah. Another thing, no one gives a damn about supply chains. Look what happened in COVID. Yeah. It was supply chains that caused so many of the problems. And that's what's weak in many developing countries. But no one's going to give you a Nobel Prize, Peace Prize, for strengthening the supply chain for drugs in Africa. It's just, it doesn't get the applause. No. So I'd be saying that's what they should be investing in. I think they have to address the issue of development in humanitarian settings. Right. And really try and put more funding into those countries that are really chronically fragile, conflict affected and vulnerable, because that's where the unmet need is, that's where the mortality and morbidity is. I think, the wish list goes on.
But what should we not do specifically?
There's aid for trade stuff, that goes on, and there are countries that Ireland has as priorities and has very good relations with, and that a lot of the time the funding flows with those good relations. So I'm not saying don't do that, but in a limited budget, moving away from funding that's purely diplomatic and sort of about building trade relationships, maybe not the best way to use your aid and humanitarian funds at the moment. Although it's very hard to separate ODA from foreign policy. It's almost impossible. I recognise that. But, in a way, I'm very loath to be critical of Ireland because they are actually increasing their aid, right? And they deserve huge applause for that. Now, where they're putting it is another question. And they need to be really investing in civil society. They need to move away from pure project-based into system strengthening. This is my personal view. Yeah. There's no standing beyond that. That's where I think it's about people and systems.
Yeah, I mean, we're talking about the government, and I think just while we're here, I mean, we're sitting here within the kind of auspices of the Irish Global Health Network, an Irish civil society network that engages all the different actors from academia and NGOs and government. How can we continue to be of service, and also how can we continue to learn particularly from our friends and colleagues in the Global South?
Well, first of all, congrats on the network, because it seems to go on and be there It's almost like a home from
not,
home
not a
for
small
most
feat.
of us. Well, no, because it links and connects people, those who've been, those who are working from here, those who will go and work in internationally. And it's very important that exists. Well, I mean, that whole role in advocacy is key, because at the end of the day, Ireland may be increasing its aid, but that's not a guarantee forever, and the pressure will come on. As everyone else drops out of the game, it's very likely that they'll say, "Hang on a second here, why are we the only ones with our heads above the parapet?" So it's really important that the network continues to drive for that sort of values-based approach, that a society that cares, and really putting dignity and inclusion and all of those things right at the centre. I know you guys. I'm not going to.
No, it's great.
Pontificate about that, but the idea that we measure health purely by mortality and morbidity it's very limiting. Because I saw in COVID, I saw in other situations, I saw in outbreaks through my whole career, that the single greatest factor that drives participation in the health system is trust. And it's not measured anywhere in the system. So I measure how many cases and how many deaths and whether I reduce mortality. Our metrics are very inadequate.
Yeah.
I'd rather be in a health system that's not quite as sophisticated as what we'd hope, but actually is caring, is community-based, is trusted by the community itself, is staffed by the community themselves, has an influence on policy. I'd rather be in that healthcare system than in one that's purely counting how many things we did. I think it's important that the network continues to really focus on that advocacy and supporting the NGOs who are out there doing the work. I mean, Ireland has a very proud history in what's being done and will be done abroad. But we also have to recognise that small NGOs are now swimming in a very big sea in many countries where there are hundreds of different partners with pressure now for self-reliance and resilience. It'll be very easy for Irish NGOs to get crushed in that mix. Funding on one side, and then on the other side is rejection, where governments are going to turn around and say to NGOs, "We don't want you here anymore. You're actually undermining our ability to be self-reliant." So how do NGOs now evolve themselves? One thing talking about the UN evolving, but how are non-government organisations, civil society organisations going to evolve themselves to be relevant to a new sort of world where we have to have a focus on national self-determination? And that probably means international NGOs really transferring their knowledge, technology, resources to national NGOs and subnational NGOs, which is not a given. That's the idea that everyone's running to part with their wares and give them to the local organisations. It's just about not happening as much as it's not happening in the UN system. Yeah. It's certainly not happening in the philanthropic system, I can tell you that.
No, well, I think we're touching on the architecture. It includes all of these, and no one piece is in isolation,
No, but it's important for your group and the network holding, it's a great forum to allow different organisations to come together, to build a kind of common view, to act as a common platform for engaging governments and pressuring government at times, which is is very good. It's I wouldn't say it's unique, but it's a very positive thing. So you need to keep going. But if you're getting cut, then that's going to have a problem as well. So I just hope the Irish government see the value of it and continue to drive the investment.
Yeah. One of the things you mentioned there is inclusion. And you speak of dignity, and you often do that. It's something you do, again, on any platform you're in. I want to ask you about something that I care very deeply about, which is the issue of stigma. You'd have come across it in so many different settings. There's societal stigma, there's internal or self-stigma. And we know that stigma stops people accessing care. We know that it stops people claiming the rights that are theirs. We know that it stops people fully participating in communities. And we know that it really disproportionately affects the people who are most vulnerable or most marginalised. You know, people living with HIV, LGBT, you know, other people, sex workers, people who use drugs. And of course, stigma goes across many different health issues, like people with obesity, for example, many health issues. We often think about stigma as, you know, tackling stigma as a social or an ethical issue. Could it be more than that? Could stigma be somewhat of an opportunity to bring people together and to focus on those issues of inclusion, build more resilient systems?
Well, yes. I mean, you can't really have an effective health system unless you address the issue of stigma. I mean, look at Ireland, TB in the 1950s, for God's sake. You know, stigma drove a generational injustice to families all over this country where people hid their TB cases in back rooms. You know, we had the same problem with disability, and people with Down syndrome been hidden. So we're not a whole long way. We decided, you know, as a society, we're not very far away from brutal stigma, exclusionary stigma, life-changing stigma. And you can't deliver healthcare in a setting like that. You have to address the issues of inclusion and stigma if you're going to have something you can call a health system or a health service. But also by addressing issues of stigma, particularly around things like you were mentioning, including things like mental health and other things, what you have then is you tap into an energy, I think.
That's right.
When people all of a sudden realise I'm not rejected, I'm included, you know, and then there's a massive spike in the way people come to the health system. Because in that sense, the health system becomes a vehicle of justice and social justice. And rather than being out on the street with placards asking for social justice, the health system can deliver social justice day to day and act as a kind of a catalyst within society. For change and for inclusion. So yes, it's one on the other. I mean, the good health system will reduce stigma and drive inclusion. Reducing stigma and inclusion will improve the health system. So it's almost a self-amplifying relationship between the two things. The problem is measuring it.
Yeah.
And then outing it in the sense of putting it out there and saying, this is our system, this is how inclusive it is, here are the areas in which we still have stigma and exclusion, and being as open about that as the number of beds in the hospital. And I think that's what's missing at the moment, the metrics that people will recognise. If you talk to anyone on the street, they'll tell you all the stories. They know about stigma, but no one ever presents it to them as a factor in the health of the health system, you know.
Yeah, thanks for that. That's really, really good food for thought. You know, as we kind of come towards...
You're the expert at that. So
well, actually, I don't think so. I think it's really good to hear. It's really good to hear your perspective on that. It really challenges us, and we have a lot of issues to deal with here in Ireland on stigma, as you say. As we come towards the end of this, and again, thank you for your time. It's wonderful just to hear what you think. You know, you've worked at so many different levels. You have worked in different contexts. You've held on to a strong set of values. You know, you talk about values based, and you actually live that. You role model that for all of us. If you had the power to make real change, specifically so that health is protected, so that people are valued, so that peace is prioritized, what 3 pieces of advice would you give us as a global health community?
No. Well, the 3 things you said, actually, you know.
That must have been a leading question, so.
It's a leading question. I think there, and it's hard to in a country like Ireland, it's hard to say it, but I think the focus has got to go on to primary health care. But it's going to be tough because it's very hard in development context to start telling people in Africa or in Asia or wherever else, now you should do primary health care. Well, we're on an absolute rocket trajectory towards tertiary health care. We should put equity at the centre of the system when in fact we have one of the more inequitable health systems in the world, developing very fast. So privatized medicine and everything else, right? So it's very hard to say what we should do because we're exactly not doing those things here. But I would really focus in on primary health care. I would focus, if you're talking about now saving lives and stabilizing health and health status around the world, I think preserving health, protecting health before you're dealing with ill health might be the way for us to go. Again, very hard to get the yellow ribbons for the old prevention. You know, it's easier to open a new children's hospital, or
well,
maybe
hopefully,
not.
maybe one day.
But you know, I call it yellow ribbon syndrome.
Yeah.
Political cycles are 5 years. They like a lot of yellow ribbons. They like to be able to open things and do whatever. And primary health care, mother and child health, vaccination. You know, where are the photo ops there? I'm sorry to be cynical, but they're the realities. And in any case, it takes 10 years or 20 years to truly develop any outcomes from a primary health care led approach, because the children you're saving and the mothers you're saving in childbirth, that doesn't come to a societal fruition for a generation. So it's not replacing the hip, you know, or whatever it is. And you know, you really feel for people. The people's aspirations to be cured when they're not healthy are real, and people's desire to have tertiary medicine and get technological fix. It's tough. And the same way, if my hip goes, I'll want my hip done, you know. Yeah. But so I do think we all, and I don't mean developing countries, the whole bloody world needs to focus more on primary health care, primary prevention, on health protection, on essentially understanding that when a child is born, there is, for the most part, they essentially have a massive potential for health, not disease. And the system's job is to protect and nurture that health, be it mental health, be it physical health, social health, all of that. And to try and create as few barriers as possible as that child traverses the world, and as much support as possible in that. And that means taking a whole of society approach. It's not just about health care. For most kids, they don't need health care. What they need is social care. They need a house. They need to live in a non-abuse environment. They need a good education, right? Then they will be healthy. So what will affect your health truly is not health. What will affect your health is truly all the other things. Nutrition, quality of nutrition. It's not just calories, like we're talking about, you know, famine and everything else around the world, but it's also the quality of nutrition that kids get. So I would have that focus on that, and there has to be a move towards that. I would really like us to look at the humanitarian and development cycle together, especially for those countries. The humanitarian development nexus for me is a unicorn. You know, many people can describe it. Most people can draw it. No one's ever seen it in reality. And my experience on the ground is that the humanitarian and development world are still very separate, very different philosophies, very different approach. And there are very few people traversing and acting as a glue that brings those two things together. They're very often funded from different parts of government, so even the governments have a different pipe for the funding. No one wants to mess with that. I think climate and health, which feeds into that more societal, multi-sectoral approach to health. But I think we're really staring down the pipe of a very bad situation now with heat waves, with cyclones. I mean, if you look at Southern Africa as a good example. I mean, 10 years ago, 6 years ago, the idea of cyclones in Southern Africa, I mean, they had lots of problems, but cyclones wasn't one of them. And we've seen Mozambique, Malawi, Zambia, been pummeled every year. I mean, that's not happening just by chance. That's climate driven. So I do think that and air pollution been another issue as well, especially in Asia. It's really becoming a problem for the ages. So I do think the climate thing is, and then the other thing for me is we really have to look at how health is financed. People see me as a big lefty and blah blah, and you know, social attitudes to health. But I'm not against privatized medicine. I'm not against private delivery of healthcare. Certainly there are areas in healthcare delivery that can easily be delivered by the private sector, private GPs or private labs or private radiology services. For me, the problem is about procurement. We should not have private procurement of healthcare. We should have public procurement of healthcare and private delivery where it's more efficient. You'll never deliver private, I don't believe anyway, that the private delivery of intensive care or maternity services is ever really attractive to the private sector. It's something that society has to do because it always makes a loss. That's a good thing. Society is able to invest in something that's not profit-making. So, but the procurement of health, the decision on health policy and who gets health care and who pays for it should be made by the state on behalf of its own people. And that's something I feel really, really strongly about because we're careering in the world as a whole towards a system. And the problem for a lot of developing countries, particularly in Asia now and South America and other places, is their health systems are getting stronger and immunization and other things have improved. But increasingly what we're seeing is more privatized healthcare. Right. And a larger and larger proportion of people's wealth or income is now being spent on basically procuring healthcare for themselves. Yeah. And they don't have the negotiation power as me, my individual self. I can't go and negotiate with the private sector. Your government should be negotiating on your behalf and then procuring that health on behalf of everybody. Whether then you pay for that through a national insurance thing or who pays for that is another issue. Yeah. Whether some people don't pay, some people do pay. I would much rather a system in Ireland, for example, rather than 5 or 6 big private insurance companies. I'd rather a national state-based insurance system where I could pay the state and the state would take care of my health. And then if someone couldn't pay the state, they get the same health care. And I think it's terrible. It's an abomination for me that 2 individuals can show up at a healthcare setting, even in Ireland, and get completely different health care. Yeah. That's and in Ireland we're not too bad. You know, we have a strong state health system. In many countries that such a state health system doesn't exist. And we're now careering down the pathway of almost essentially a totally privatized system in many developing countries. Yeah. People aren't seeing this coming, and it's coming down the pipe. And we're going to see people spending a huge proportion of their income on basic health care, which to me is unacceptable. We have to address that's as much a political issue as it is anything else. Sorry, I'm being very philosophical now.
Well, it's
very
great.
Practical, you know.
That's great. We want you to be philosophical. And speaking of philosophical, I mean, we had hoped that we had our hopes on you for President of Ireland. Unfortunately, you know, you didn't run for that, but we're happy now. Catherine Connolly did get that.
Yes.
But what's next for you, Mike?
Oh, I don't know. First of all, congrats to Catherine. She's fantastic, and it's great to see. You know, the one thing about the presidents in Ireland over time, we might give out about our politicians. Although I think we've got quite a good political class in Ireland. Actually, when I compare them to what I've experienced in other settings, it's you know we need to be. We live in a pretty good country. And our politicians at least have that connection with their electorate that I think is respectful, and they try to do their best.
So you still might run for president?
No,
then?
I think the great thing about the presidency in Ireland is that the people who've occupied the presidency, certainly of the last 20, 30 years, they really have represented the values of the Irish as opposed to politics of the Irish. And the practical reality of government and having to make decisions and set priorities often means, you know, they can't be talking about values all the time. They've got to get on and build things and do things. Whereas having presidents like Michael D. Higgins and Mary Robinson and Mary McAleese and now Catherine, who can speak to what we feel.
Yes, and who we are.
I think it's a fantastic thing. Now, I know people say, you know, it doesn't have any power and everything else, but I think it does have a lot of power.
Well, values have power.
Yes.
We've been talking about that today.
And so I wish her luck. I think she's doing well. But me, I'm not a politician. I'd probably get myself impeached in the first 3 days, you know. I'm not a politician. I'm a technician. I don't know. I don't have any plans.
That must be nice.
I'm doing bits and pieces. I'm doing some work with the African regional director. I'm doing some bits and pieces with local NGOs and
In
speaking
Galway,
to the
right?
chief fire officers next week or next month. And so I'm paying back a lot of people who've asked me over the last number of years to do things. And I had to say no because I was running around the world. Now I'm caught. So I'm sort of... and I actually I enjoy more now actually working with smaller organisations, doing whatever notoriety I have to at least help them to get more attention, and that's nice. And I maybe I have one more big gig left of me, but I don't know. I don't think so.
Or not yet. It hasn't shown itself yet.
No, the people have been doing my head in asking me, am I going to run for Director General at WHO?
Oh, God.
And you said, well, maybe WHO might not be around by the time that comes up.
Yeah.
So, no. I'll work with the local NGOs and maybe some international work, but we'll see what happens.
Well, thank you for saying yes to us. Thank you for your support to IGHN and to Global Health and the Global Health community in Ireland. Thanks for your time. We're really, really grateful. And, huge thank you. If you enjoyed this episode, do follow the Irish Global Health Network. Stay connected to us so that you can enjoy this conversation, future conversations. And if you'd like to revisit our first discussion with Mike, which was also fascinating, you'll find the link in the episode, in the URL. So thanks for listening, and we will see you soon.